Hello, I'm Dr. Manish Singhal, medical oncologist at Apollo Hospitals, Noida and Delhi. We are presenting the ESMO update meeting. ESMO is European Society of Medical Oncology meeting, which was held this year in October 2023. This is a meeting which is attended by global experts across the world, and it provides all the up-to-date information about various cancers. And we are happy to announce that this meeting was held under the aegis of Apollo Hospital and was held on 4th of November at Radisson Blu, Sector 18, Noida. And we were able to invite faculty across Delhi NCR and all other cancer experts, which shared their views on these updates, and was attended by a lot of students. And I'm sure that these updates includes not only about breast cancer, lung cancer, GI cancers, gastrointestinal cancers, GU cancers, but also supportive care and sarcomas. It's so very important to keep up to date to provide the best possible care to our cancer patients. And I hope that you like these updates, and we will keep introducing more updates like this in the future. Thank you.
So, good afternoon everyone, and first a heartfelt thanks to the Chair and Dr. Manish to give me this opportunity. And I'll be talking about the evolving trends in management of HER2 positive metastatic breast cancer. So this is the outline of my presentation. I'll be going on to the introduction and some unmet needs which are there for second line HER2 positive metastatic breast cancer, also some recent advances and probable treatment algorithm of what we have as of now, and some conclusions. So, if I talk about breast cancer, we know that it is the frequently diagnosed cancer and the leading cause of cancer-related death among women. And we know about 1/3 of the women will become metastatic after diagnosis, and most breast cancer deaths are attributed to the metastatic disease. So, HER2 positive breast cancer cells are associated with aggressive disease that we all know, but we have targeted options for the same. And 15 to 20% of invasive breast cancer cases are HER2 positive, as we define by IHC or by ISH. So these are the breast cancer subtypes, and if we talk about the HER2 positive, we have about hormone receptor negative and HER2 positive in a team of 7.4% and about 13.3% which are triple positive. So in all, the HER2 positive would amount to 20.7%. So we know that there have been many discoveries in cancer treatment, but this was one of the landmark deliveries, the discovery of the HER2 factor receptor oncogene, and it has shaken the foundation of cancer treatment, and it confers an aggressive tumor behavior, but also there is an opportunity for targeted therapies. And if you go about the timeline, you can see here we started way back in 1998 with trastuzumab was started being used, subsequently approved in 2006-07. And then we have lapatinib, then we had the dimer, the molecule which inhibits dimerization like pertuzumab. We got the TDM in the way, and now we have a plethora of drugs, with the latest one being TDXL. So if you see the HER2 signaling pathway, it is a receptor which is present on the cell surface, and it has a ligand. And the trastuzumab molecule basically binds to it and stops the downstream signaling pathway. And while pertuzumab, it inhibits the dimerization of the two receptors, so that the downstream signaling pathways, which are usually the RAS and the PI3K pathway, which are not activated. So the various drugs which we have at the moment and which would lead to some form of a HER2 blockade is obviously our very old friend trastuzumab, which would block the HER2 new receptor and thus would stop the downstream signaling pathways. We have pertuzumab, which would basically stop the dimerization of HER2 with HER1 or HER3, and obviously then inhibit this pathway. We have the TDM1, which formed the basis of our second line treatment of till late, where you have this molecule which comes with a payload, which attaches to the ligand, and this payload, which is a DM1, is attached to the lysosome, and it goes intracellularly and then helps in microtubular inhibition. And now we have one of this phase 2 study. Now coming on to the DESTINY-Breast02, this was the study which basically compared a phase 3 open label multi-center study with patients who had been previously exposed to TDM1. So these patients had already been exposed to TDM1. They were HER2 positive, and they were either given this molecule TDXD or the treatment of choice as per the physician, which could have been a combination of trastuzumab, capecitabine, or a lapatinib capecitabine. The primary endpoint was PFS, secondary endpoint OS, and then the other secondary endpoint was the ORR, DOR, and PFS safety. So the median duration of follow-up was about 21.5 months in the TDXD arm. And you see the graph over here as compared to the physician choice. The graph is widely separated, and the hazard ratio is set very well in favor of the PDXD arm, something which is difficult to imagine. A hazard ratio of 0.35. There's no question of the efficacy of this molecule. Also, if you talk about the key secondary endpoint OS, so at the end of 1 year, 89.4 versus 74.7. And at the end of 2 years, 65.9 versus 54.3. And if you see the graphs have started to separate after 6 months of duration, and they tend to keep on separating till the last follow-up. So this is how in the TTC arm, 69% of the patients who discontinued therapy received a new systemic anti-cancer treatment, while it was about 25% of the patients received TDXD in the post-trial setting. Now the third trial, because the obvious question here is that we already have an established drug in the second line, which is TDM1. So how do we do not have a head-to-head trial? Somebody would raise a question that TDXD head-to-head with TDM1 in a setting where the drug is supposed to be there. So this is the DESTINY-Breast03 study, unresectable metastatic HER2 positive breast cancer that has been previously treated with trastuzumab and taxane. This could have been clinically stable treated brain metastasis, and there should have been a gap of about 2 weeks between the end of whole brain radiation. Stratification factors, hormone receptor, prior treatment with pertuzumab, and history of visceral disease. And brain metastases were also measured at baseline and also at progression. A randomization 1:1 absolutely standard, TDXD and TDM1 in the standard doses. Primary endpoint being PFS and the key secondary endpoint being OS. So coming on to the baseline characteristics, the baseline characteristics were pretty well matched in terms of the geographical location, and Asia had its fair, pie of cake over here, where we had about 57% of the patients from there. So we had enough population from Asia to, correlate the benefit. Then among the baseline characteristics, whether it was HER2 status, ECOG performance status, hormone receptor positivity, history of brain metastasis, baseline and visceral disease. So all confounding factors which might change the outcome were also, randomized properly so that there is no confounding factors. And approximately 60% of each patient had received prior pertuzumab. So the prior pertuzumab confounding factor was also very well balanced, and also the number of lines of therapy which were previously there. So coming on to the primary endpoint, and again the graph is excellent as compared to TDM1, and you can see the hazards 0.333, something which we really got in the previous DESTINY-Breast02 as well, and this was 4 times longer as compared to TDM1, and the graphs were widely separated in the favor of TDM1, 28.8 versus 6.8 months. Then the secondary endpoint, which is the PFS by investigator, 70% reduction in progression or death. Again, the hazard ratio of 0.3, the graph set very well. And the key secondary endpoint being the overall survival, again in the favor of the TDXD arm, whether at cutoff at 1 year, which is 94 versus 86, 77.4 versus 69.9 at the end of 2 years, the hazard ratio of 0.64, statistically significant. So now coming on to the overall survival by subgroups, and this is the first plot, and you can see here, each and every confounding factor, be the hormone receptor status, prior pertuzumab use, baseline visceral disease, prior lines of systemic therapy, also the baseline brain metastasis. Everything in the favor of the TDXD arm, hazard being the tune of about 0.6 to 0.7. If you talk about the PFS, again similar sort of results, the hazard reaching about 0.3 in majority of cases, be it brain metastasis or hormone receptor or prior pertuzumab. Also, in terms of brain metastasis at baseline, and patients who did not have brain metastasis at baseline, you could see here there was a big dip in curve when TDM1 was used in such patients, and the median PFS was only 3 months, while the median PFS of about 15 months was achieved. At in terms of death, none of them have been reported in any of these arms. 56.4 versus 51.7 in terms of more than grade 3. The median duration of treatment with TDXD has been achieved to be 18.2 months. Obviously, the problem with TDXD has been the lung, which I am going to talk about in a minute. So, types of adverse events: exposure adjusted incidence per patient per year, 90 about 0.87 versus 1.43 in the TDM1 arm, and 0.46 versus 0.72 in terms of grade 3 events. And if you are coming on to the specific side effects, we have the hematological side effects. So hematological side effects slightly higher in terms of anemia, but the platelet and the platelet functions are more dysfunctions are more in TDM1 as we know. The GI side effects slightly higher also in TDXD arm, and the neutrophil count decrease is also more in the TDXD arm. But the problem which we really need to care about is the ILD and the pneumonitis, and the incidence of grade 1, 2, 3 pneumonitis is much higher as compared to TDM1. So with longer treatment exposure and follow-up, the ILD pneumonitis rate has increased from 10.5 to 15.2, and there were additional 4 grade 1, 8 additional grade 2, and no additional grade 3 events. So the overall incidence of grade 3 event was same in the PFS interim analysis. And this is something which we really need to monitor, that whether the patient has some lung comorbidity and how the patient is behaving in terms of its pulmonary functions. So coming on to the conclusions, TDXD has demonstrated clinically meaningful and statistically significant improvements in OS over TDM1, with continued PFS benefits in patients who have been previously treated with trastuzumab taxane, reduced risk of death by 36%, 4 times longer median PFS as compared to TDM1, and objective response rate in 78.5. OS benefit is consistent in all the pre-specified subgroups, and with a longer treatment duration, it continues to demonstrate a manageable and tolerable safety profile, but we really need to be worried about the lung part, and we need to monitor it. So these are the latest NCCN guidelines. So we can see here that after the first line, when we have given the patient pertuzumab and trastuzumab, in second line, SAM trastuzumab creates a category 1 preferred as of now, and TDM1 has been moved to third line.